mutation negative advanced lung cancer. I hope I'm audible. Hello? So,
yes, you are.
While all of us like to, next slide please, while all of us love to treat, we all send NGS on most of our patients with the lung cancer, especially the adenocarcinoma and the adenosquamous. Can you move to the next slide, please? No, the previous one. I apologize for this. I'm not able to control my slides because I'm calling in from the mobile. The computer was not working. So anyway, we all understand and we send NGS on most of our lung cancer patients. And while a lot of them will have targetable druggable mutations, there'll be a large number of patients who will not have any mutations and whom we will have to decide what systemic therapy and what approach we will be taking. In fact, it appears from the data from TMH that the patients without druggable mutations is actually a little bit more in the subcontinent. So for those patients, next slide, please. We have an algorithmic approach where we look at the histological subtype, we look at we do the molecular profiling. If they have no mutations, we look at the PD-L1, and now more and more we are also looking at the tumor mutational burden. We have learned to subdivide these patients who are mutation negative into 3 big subgroups that are PD-L1 more than 50%, PD-L1 between 1 to 49%, and those who are PD-L1 negative less than 1%. Next slide, please. We have the basic armamentarium at our disposal currently for these patients is chemotherapy, age-old chemotherapy, targeted therapy that was introduced in the early 2000s, and of course, the latest kid on the block, which is immunotherapy. And through the next slides, I will show you how the treatment has evolved, and we will spend most of the discussion basically on immunotherapy. Next slide, please. So, of course, when we are treating patients with stage 4 lung cancer, we of course have to apply the general principles. We need to palliate their symptoms. If they have bone and brain metastases, we offer them palliative radiation, orthopedic stabilization. We offer them denosumab, bisphosphonates, and pain control. These days, however, something that I find a little difficult in advanced lung cancer is how to counsel these patients. Because while at the end of the day, it is incurable for majority of the patients, there will be a small subset of patients who could have long-term control. So how do we counsel the patient, keeping them hopeful, but also preparing them for the reality of the disease, despite all the advances that have taken place? The fact remains that for most of our patients, it is incurable. Next slide, please. I will just briefly touch on chemotherapy because all of us are quite familiar with the chemotherapy regimens used in advanced non-small cell lung cancer. We know that platinum doublet is better than supportive care alone. We know that patients who have a good performance status, platinum is better. There appears to be better response rate, and there were some trials that showed perhaps an increased overall survival. But for most of us, we substitute carboplatin, where we find that cisplatin cannot be tolerated. And as lung cancer is mostly seen in the elderly, I feel that for most of us, probably carboplatin is the agent of choice when we combine with in the platinum doublet. Single agent chemotherapy for the elderly is definitely an option. There was the Elvis trial that showed that vinorelbine alone was better than by supportive care. Sometimes we may consider non-platinum doublets. And of course, we all understand that based on the histology, whether they are non-squamous or squamous, we will choose the appropriate partner for the platinum doublet. Especially in non-squamous, we will consider pemetrexed, and in squamous, gemcitabine or the vaccines. Next slide, please. So, in 2000, we looked at this trial, which was the role of bevacizumab in non-small cell lung cancer. Patients were given paclitaxel. There were 2 arms: was paclitaxel and carboplatin alone, or the combination along with bevacizumab. There was a slight improvement in median overall survival, 12.3 months in the bevacizumab plus chemo arm versus 10.3 in the chemo alone arm. This was statistically significant. They found that there were a larger number of patients who were alive at 1 year, 51% in the Bev plus chemo arm versus 44% in the chemo alone. And the difference persisted at 2 years. The response rate was significantly higher in the Bev plus chemo arm versus chemo alone, however, at the cost of increased toxicity. A couple of years later, next slide, please. The toxicity profile, of course, was increased neutropenia in the Bev plus chemo arm, an increased rate of hypertension, proteinuria, and the one that is probably the most horrifying for patients is the increased risk of bleeding events. And with that, it came about that patients who were squamous, who had untreated brain metastases, and those who were at a risk for increased bleeding should not be chosen for this particular regimen. Next slide, please. In 2013, they looked at the Point Break trial, looked at bevacizumab with pemetrexed and carboplatin versus bevacizumab with paclitaxel carboplatin, and they found that while there was no difference in overall survival, there was a slight increased number of patients who were alive at 1 year with the PEM plus PEM carbo-bev arm as compared to pacli carbo-bev arm. Next slide, please. The one big difference that did stand out was that the pemetrexed plus platinum plus bev had a better toxicity profile as compared to the paclitaxel carbo-bev arm, especially especially the neuropathy, which we all know can be very debilitating for patients. There was a combined analysis of both the ECOG 4599 and Point Break, and they found that this combination did show survival benefit for those less than 75, but none for the older age group. And I think now most of us are probably not using this combination in favor of the newer therapies that have come about. Next slide, please. Just a brief point about another targeted agent, ramucirumab. This has been approved in the second-line setting in combination with docetaxel, as it provides a slight improvement in OS and a slight improvement in performance of progression-free survival. Next slide, please. But the real thing I think that has changed treatment for patients with non-small cell lung cancer who do not have any druggable mutations is the advent of immunotherapy, as we're all familiar with the NCCN guidelines. And based on the PD-L1 levels, they have divided treatment of these patients. If they are more than PD-L1 more than 50%, PD-L1 1 to 49%, and PD-L1 less than 1%. Next slide, please. Next slide, please. So I will start with the use of immunotherapy as a single agent in advanced non-small lung cancer with this trial, which is the Keynote 024. This looked at patients who had a PD-L1 more than 50%, and they were randomized to pembrolizumab alone versus a chemotherapy doublet for 4 to 6 cycles. As you can see here, there was a significant difference in the progression-free survival. The response rates were higher, 44% in the pembro arm versus 27.8% in the chemo alone arm. The grade 3 and higher adverse events were lower in the pembro group. And there was a 2019 survival update which showed that for the patients with PD-L1 more than 50%, overall survival with pembro alone was 30 months as compared to 14.2 months with chemotherapy alone. It's almost doubling your survival. And at 3 years, more than 40% of patients were still alive in the pembro group as compared to 25% with the chemo alone. I have to admit that I think that in this trial, the chemo alone arm also did quite well, because most of us know that with chemo alone, most of the patients do not live beyond, the 1 year survival is about 15%, but perhaps because the crossover allowed, patients got on to receive pembro or immunotherapy in the second line setting. Next slide, please. As we talked before, the side effects were much lower with the pembrolizumab compared to the chemotherapy group. Next slide, please. But what we did realize that it is not all roses with immunotherapy, because there are immune-mediated adverse events seen in 30% of the patients. The grade 3 or higher immune-mediated events were about 10% in this group. And the most common was hypothyroidism, followed by hypothyroidism and pneumonitis, infusion reactions, etc. Next slide, please. I'm sorry, can we go back to the previous slide? Oh, yeah, this slide. The other trial that bolstered the use of single agent pembrolizumab in the patients with a PD-L1 score more than 50% is the KEYNOTE-042, which looked at the use of pembrolizumab versus chemotherapy alone in patients who had a PD-L1 more than 1%. And as we can see here, for the entire cohort, which includes patients from 1 to 50% and higher, there was a significant difference in overall survival. In the pembro alone group, it was 16.7 months versus 12.1 months with the chemotherapy. Next slide, please. Of course, the benefit was higher in those who had a PD-L1 more than 50%, and in that subgroup, the overall survival with pembro alone was 20 months versus 12.2 months. So the study seemed to think that most of the survival benefit was derived from the patients who had higher levels of PD-L1. The one point, however, that is interesting in this trial is that even for the patients who had a PD-L1 between 1 to 49%, pembro was not inferior to chemotherapy, as the median overall survival was more or less the same. And so perhaps for some patients who have a lower PD-L1 but are not willing to take chemotherapy, pembrolizumab alone for the subgroup could still be an option. Next slide, please. What about the combination of immunotherapy with chemotherapy? We have the KEYNOTE-189 published in 2018. This looked at stage 4 non-squamous non-small cell lung cancer without an EGFR or ALK mutation. And they randomized the patients in 2:1, pembrolizumab plus pemetrexed and carboplatin or cisplatin versus placebo and chemotherapy. The pembrolizumab was continued up to 31 cycles after the chemotherapy was discontinued. Next slide, please. In this, the PD-L1 assay used was 22C3. We will see that with nivolumab, the different assays used. And they had 1/3 of the patients with PD-L1 less than 1%, about 1/3 between 1 to 49, and 1/3 of the patients had a PD-L1 more than 50%. Next slide, please. As we can see here, for the entire cohort, the overall survival was significantly in favor of the pembro plus chemotherapy combination. It was, at the time the trial was published, it was not reached versus 11.3, and in the 2020 survival update, it was 22 versus 10.7 months. So there was a doubling of the overall survival with the use of pembrolizumab in the patients with a PD-L1 more than 1%. The progression-free survival was also almost double. And the chemotherapy and the toxicity of pembro plus chemotherapy was as expected. The one thing that the authors wanted to point out, that there was an increased number of patients in the pembro plus chemo arm who discontinued the chemotherapy. In this subgroup analysis, the further point that I wanted to highlight was that the overall survival was improved regardless of the PD-L1. So while, of course, it was higher for those who had more than 50%, even for those who had less than a PD-L1 less than 1% or a PD-L1 between 1 and 49%, the addition of pembrolizumab to the chemotherapy was superior to chemotherapy alone. Next slide, please. KEYNOTE-407 was looked at pembrolizumab plus chemotherapy for the squamous non-small cell lung cancer, and in this trial too, we find that there was this significant improvement in overall survival for the combination of pembro plus chemotherapy. So both for non-squamous and squamous non-small cell lung cancer, the combination of pembrolizumab plus chemotherapy is a valid option. The response rates are also higher in this trial too. The response rate was almost 60% with the combo compared to 37% with chemotherapy alone. Next slide, please. The grade 3 or higher adverse events in this trial seem to be similar in both groups, about 68%. Again, they had the higher discontinuation rate, however, with the pembro plus chemotherapy arm, almost double as compared to chemotherapy alone. Next slide, please. So we've looked at pembrolizumab alone, we've looked at the combination of pembrolizumab plus chemotherapy. What about the combination of a targeted therapy to immunotherapy and chemotherapy? What is the additional benefit? This was answered by IMpower 150 trial, which had 3 arms, atezolizumab with chemotherapy versus atezolizumab with chemotherapy and bevacizumab, and the last arm, which was the bevacizumab plus carboplatin and paclitaxel alone arm. And the trials, the trial results that have been published have been looking at the bev carbopacli versus bev carbopacli plus atezolizumab. Next slide, please. In this trial, the addition of immunotherapy to the bev carbopaclitaxel versus bev carbopaclitaxel alone showed there was a significant improvement in progression-free survival and overall survival. The rate of patients who had progressed at 12 months was almost double. The number of patients who were alive at 12 months was almost double in the Immuno bev carbopacli arm as compared to the bev carbopacli arm alone. And the risk of death was lower and the response rates were higher. Next slide, please. However, I think one of the problems with this in our setting will, of course, be cost. And given that we have such good results with immunotherapy plus chemo alone, I would question the use of the addition of bevacizumab in the current scenario, except for one particular group, because patients who have EGFR or ALK and who have progressed on the targeted therapy can go on to receive immunotherapy in this combination, because this subgroup was included in this IMpower 150 trial. A couple of my last slides are looking at the use of combination immunotherapy, and we know that there is now data for Nivo plus ipilimumab given by this Checkmate 227 trial, which is a very complicated trial divided into part A, 1A, 1B, and 2. Here we have just the part 1, in which patients were divided into two groups. In the first group, they about 400 patients received a combination of nivolumab plus ipilimumab. The second group received chemotherapy alone, and the third group received nivolumab alone. In the 1B part of this trial, the patients were subdivided, with those who had PD-L1 less than 1% were given either nivo plus ipi or chemotherapy alone, and the last group received nivolumab plus chemotherapy. There were co-primary endpoints for nivolumab plus ipilimumab versus chemotherapy, which is what was published. They looked at the PFS in these populations based on TMB, and also the overall survival in the entire cohort. Next slide, please. So the first results that were published were the combination of nivo plus ipi in patients with a high tumor mutational burden. We know that patients who have a TMB more than 10 megabase appear to have improved results with this combination. The progression-free survival at 1 year was 42% in the combination arm versus 13% for chemotherapy alone, with a higher response rate and not an increased rate of grade 3 or grade 4 toxicity. So this held true regardless of the PD-L1 expression, whether it was more than 1% or less than 1%, regardless of the histology. And it appeared that even patients who had low PD-L1 but a high TMB benefited from this combination. Next slide, please. And this held through also in their progression-free survival, where you can see that at 1 year, 43% in the combination arm was alive as compared to 13% alone in the chemotherapy arm. Next slide, please. Next slide, please. So this was the subsequent follow-up results on this trial, which looked at the combination of nivolumab plus ipilimumab versus chemotherapy alone for all patients. And in this, they found that there was a difference in overall survival in those patients who had a PD-L1 more than 1%, about 15 months in chemotherapy alone versus 17 months, a 2-month survival advantage. The interesting point in this that the median duration of response was 23 months as compared to 6.2 months with chemotherapy alone. Next slide, please. And even for patients who had a PD-L1 less than 1%, the difference in overall survival remained. And in fact, it was increased with chemotherapy arm doing 12 months alone versus the combination reaching up to 7.2 months, a difference of about 5 months. Next slide, please. And this is the entire cohort, which all showed benefit, survival benefit. Next slide, please. There was some secondary endpoints also that were evaluated in this trial. For patients with a PD-L1 less than 1%, the Nivo plus chemo combination had an improved performance, progression-free survival. The hazard ratio for progression or death was also significantly in favor of the combination of Nivo plus chemotherapy, but the overall survival was not that different. In the PD-L1 more than 1%, they did manage to show that the combination of Nivo plus EP versus Nivo alone had an improvement in the duration of response. The majority of the improvement seen in those with a PD-L1, more than 50%, where the duration of response was almost 3 years. Next slide, please. Next slide, please. This is the last trial, which was recently discussed in ASCO 2020, where they looked at the combination of nivolumab with ipilimumab with 2 cycles of chemotherapy versus 4 cycles of chemotherapy alone. The primary endpoint was overall survival, and there were secondary endpoints of progression-free survival, response rates, and efficacy based on PD-L1. Next slide. They showed that as regards the primary endpoint, there was the combination of Nivo plus EP cycles of chemotherapy was superior as compared to 4 cycles of chemotherapy alone, with a difference of about 5 appeared to benefit. So perhaps in the future, the PD-L1 may not matter for those patients who may not matter if you are going to be receiving a combination of Nivo plus EP. Next slide, please. Because I focus mainly on the first-line therapy, I just have one slide that has shown that for the patients who do not have a mutation and who have received chemotherapy alone, do we have several options when they progress? In the past, we had only docetaxel or gemcitabine, but now we know that immunotherapy has stepped into this particular scenario as well. And we have 3 agents that are currently approved in the second-line setting, which is nivolumab, atezolizumab, and pembrolizumab. And here I have the results of Nivo versus docetaxel, which was one of the first trials that was published in 2014, and that showed that there was about a 3-month survival advantage for immunotherapy with docetaxel, with nivolumab versus docetaxel alone. Next slide, please. So my conclusion actually is that in today's era, can we go to the next slide? Next slide. Is that for today, the inclusion of immunotherapy for patients without a druggable mutation has improved the survival. There were average survival prior to immunotherapy was anywhere between 10 to 12 months. With the arrival of targeted therapy, we improved it 2-3 months more. But now there are some patients, albeit low in number, who are able to survive for almost 3 years. The important point that we have to, the factors that we have to consider, however, when we are selecting therapy is, of course, tumor histology, the PD-L1 score, but eligibility for immunotherapy. While we all like to think that these toxicities are decreased as compared to chemotherapy, there still remain significant toxicities with immunotherapy that can prove to be fatal. I will share one patient of ours who was given pembrolizumab and had a very good response. However, she developed pneumonitis and we had to give her steroids. After the use of steroids, she ended up developing a fungal pneumonia and actually died from the fungal pneumonia, which was quite heartbreaking given that she responded for her metastatic lung cancer. So the eligibility for immunotherapy, the appropriateness of that patient for chemoimmunotherapy, and if we are using bevacizumab, then the eligibility for bevacizumab has to be looked at. I think one of the biomarkers that will emerge with more use in the future is the tumor mutational burden, because we have seen how TMB trumps PD-L1. For a high TMB can trump PD-L1. And perhaps
Anubha, you have to wind up now.
Yeah, this is my last slide. So I think perhaps in the future we will not be using chemotherapy at all, and maybe just looking at a combination of PD-L1 and CTLA-4. Thank you so much.